So catch-up vaccination means administration of vaccines at a later date or age if they have been missed at the recommended age. So if someone was to get, say, a typhoid at 6 months, but they missed it, then anytime they come to you, when you give the vaccine, that is known as catch-up vaccination. If there is a case of missed vaccines, the previous concept long time back was that we need to restart. But now they say there is no need restarting of the entire series, because if you give the dose whenever they come to you, it is going to induce an equal immune response. But when you do this, you must know that when you're doing catch-up vaccination, you may have to give multiple vaccinations over a short period of time. So in that case, the only thing you have to remember is that the vaccine doses must not be offered 4 or less days from the minimum desired interval. So the desired interval is at least 28 days. So you cannot give it before 24 days. So even if you have to give early, you can give it at 24 or 25 days, but not less than that. Some of the general rules for catch-up vaccination are that 2 or more inactivated vaccines can be administered at the same time or at any interval without affecting the immune response. So there are some parents who will agree to having 4 pricks for their child during the catch-up period, but there are some who will not want to do 4 together. So they may say, okay, you give 1 today, maybe 1 after another few days. So that is also allowed as per the current recommendation. The inactivated vaccine can be given together with a live attenuated vaccine or at any interval with a live vaccine. 2 live vaccines should be given simultaneously. 2 live vaccines should be given simultaneously, or if they're given at different periods, there should at least be a 4 weeks gap between the 2. So whenever you're giving these vaccines, so you have to give 4 vaccines and you have only 2 thighs. So in between the 2 vaccines which you will put in the thigh, there should be a gap of at least 5 centimeters between the 2 injection sites used for the different vaccines. Now, this is quite simple and it is important to remember these general rules. Now, what is the current latest guidelines of the ACVIP, which is published in 2024 February? So I'll be showing you the catch-up vaccination schedule from here. So if you look, last class which I had taken, we have discussed these this kind of a chart in detail. So here you know that just to recapitulate, the yellow color indicates the vaccine which is to be given at the recommended age. For example, BCG is to be given at birth. The green color is the catch-up age. So when you talk of BCG, you can do a catch-up up to 5 years of age. And blue again is vaccination in special situations. So if you look at all the vaccines that we are giving in our current schedule, you will see that there is a catch-up period which has been given for nearly all the vaccines. Okay, all the usual vaccines that we give. So whether it's BCG, hepatitis B, polio, the pentavalent, PCV, rotavirus. Only thing you have to remember, you see the green line at rotavirus ends at 8 months. So this is, we know all of us that beyond 8 months, we cannot give the rotavirus vaccine. Then MMR also, you see, there is a green area. Similarly for typhoid, hepatitis A and chickenpox, and also for the Tdap vaccine. So we'll take few of these vaccines one by one. So suppose you have a child who has come to you at say 1 year of age and he has not got any vaccine till now. Quite a common situation. Or they may have got 1 vaccine and the rest they have forgotten, or for some reason the parents could not immunize. So in this situation, how do you schedule the vaccines for the catch-up schedule? So in the first visit, it is suggested that if the parents are willing to take multiple doses, then you could start with, because you say the child is more than a year, so you could just start with MMR along with the pentavalent vaccine. Now, in the pentavalent, whether you use the whole cell or the acellular, it doesn't matter. We have the IPV, which is incorporated into it, Hib, as well as the hepatitis B. So this will be taken as the first dose. Now, in the pentavalent, another important thing to note is that if the child is more than or equal to 7 years of age, then we will give Tdap instead of DTAP or DTWP. OPV, IPV is only given if the child is less than 5 years of age. Hib also only if the child is less than 5 years of age. Then, after a minimum gap of 28 days or the second visit, you could give the BCG. Now, BCG, if you looked at the schedule here, BCG, if you look at the schedule, it can be given up to 5 years of age. So, in the second visit, you could give BCG and only if less than 5 years of age. The other things that are given are, again, the second dose of DTP, DTAP, IPV, OPV if you have given only OPV, say in the government sector, but in the private sector, we would like to give IPV, Hep B and Hib second dose. The third visit, again, which is 28 days after the second visit, you will continue with the IPV3 MMR second dose and the typhoid TC. In the fourth visit, which will be 6 months after the first visit. Now, this is important. The fourth visit is 6 months after the first visit. Now, this has been done to accommodate the schedule for the hepatitis B third dose. So here you will again give the third dose of DTP or DTAP, the IPV booster, and the hepatitis. This should be hepatitis B3. So this is to adjust the hepatitis B third dose that we have put the fourth visit after a month. So this is a suggested schedule for the totally unimmunized child. So I don't think so there should be a problem with this. Then we come to the recommendations for the 7 to 18 years. So again, if the child comes between 7 to 10 years, we have already discussed, you could give a dose of the Tdap. This is what is recommended in Tdap, that is at 11 to 12 years. And at 13 to 18 years, if the patient has not got a Tdap before, you could give the dose again. So this is catch-up. Then coming to whether it is the quadrivalent cervical cancer vaccine or the 9-valent one, the usual recommended doses would be between 11 to 12 years, or at least in girls from 9 years of age. And this you can do a catch-up up to 18 years. So this you will give, if it is below 14 years, a 2-dose series, and above 14 years, it will be a 3-dose series. For MMR, varicella, hepatitis B, and hepatitis A, we will do catch-up with the usual doses. So MMR, chickenpox, and hepatitis will be a 2-dose series, which I'll be discussing the gap. The hepatitis B will be a complete 3-dose series. Hepatitis A will be a 1 or 2-dose series, depending on whether you're using a live vaccine or a killed vaccine. Typhoid, we know as per WHO recommendation, 1 dose. Flu, JE, pneumococcal, meningococcal, only if they are indicated. Flu now is a 1-yearly dose. So if the patient has some problem, then you can do like say is an asthmatic, then you can start that vaccine at that time. Now, JE vaccine for some of us is recommended at for example, if you talk of Northeast in Assam, we do give JE vaccine, and we have a catch-up up to 18 years of age, 2 doses, 1 month apart. So, but this I have not shown in green because this is not for all areas, though there are many districts in India which have now become JE endemic. Okay, so I think this is also easy to understand. So if you look at hepatitis B catch-up, the schedule which we do for catch-up is 0, 1, and 6 months. No pre-vaccination screening for anti-HBsAg level is to be done. If the gap is up to 6 months from the first dose or 1 year between the second and the third dose, there is no need to restart the schedule. If the gap between the first and second dose then it's more than a month, then you give the second dose as soon as possible, and the third dose after a gap of at least 8 weeks from the second dose. If the third dose is delayed, then you administer as soon as the patient comes to you. So this is something which is important for us to remember about hepatitis B vaccination. Coming to the DTWP or DTAP catch-up, for children between 1 to 7 years, we give 2 doses, 1 to 2 months apart, and the third dose is given from 6 to 12 months after the second dose. If partially immunized, then complete the remaining doses, and a total of 5 doses are to be completed before 7 years of age. So this is for complete immune response. As we have already discussed, if the child is above 7 years of age, the Tdap 1 dose is followed by a TD 1 to 2 months apart and a third dose after 6 to 12 months of the first dose. Now, if you're giving a Tdap at 7 years, remember, the child will receive the scheduled Tdap at 10 to 11 years of age. So they will receive this Tdap also as per the schedule. Now, if the child comes as an adolescent, then you give a 1 dose of Tdap followed by TD every 10 years. If Tdap is not received in pregnancy, it should be administered immediately postpartum. This is to prevent or give the cocooning effect to the baby, to prevent neonatal pertussis. In adults, 1 dose of Tdap is recommended if they have never received any Tdap before. Coming to PCV, the pneumococcal conjugate vaccine, if the child is more than 12 months of age, then you give 2 doses 8 weeks apart. But if the child is more than 24 months, then we know that a single dose is sufficient to give lifelong immunity. For MMR, the catch-up says that you have to give 2 doses 4 weeks apart. If the child has received any MMR before, then you give 1 dose. In the campaign mode, the MMR vaccine is given irrespective of the previous doses. Similarly, for varicella, important to understand that if the child is below 13 years of age, then you give 2 doses 3 months apart. If the child is above 13 years of age, then 2 doses 1 to 2 months apart. For HPV also, the vaccines, if they have never got, you have to administer it to all girls above 9 years of age. Between 9 to 14 years, we give 2 doses 6 months apart, whether it's the quadrivalent or the nanovalent. And above 14 years, it is 3 doses, 0, 2, and 6 months. So that is all, I think, a very short presentation on the catch-up vaccination. And if there are, I think there'll be more discussions that will be easier to do.
I think in last talk of yours, we have done the discussion,
Yeah.
and if at all there is any question, then we will take it, ma'am. Till now,
Sure.
there is no question, ma'am. Ma'am, most of the patient um, are coming to OPDs for influenza, with children having, or this is one set of patient who come for influenza, another set has taken government vaccines, 3 vaccines of provided by government in 6, 10, 14 weeks. For them also, we should do a catch up with the wholesale.
Uh, if they have done 6, 10, and 14 weeks, then you will do, if they have taken 6, 10, 14, then I think they've taken all 3, no?
Okay.
But if
And
suppose they've taken 2 vaccines, then ideally, say they have taken 6 and 10 weeks and they come to you for the next dose, then you will ideally, preferably give a wholesale vaccine. But if the parents insist that they want a painless one, that is also not a problem because you have already induced a good immunity by using a wholesale as a priming dose. So that is also fine.
ma'am, in your practice, do you recommend wholesale or acellular?
I recommend both. So it depends on what they want. Some of them are very finicky. So they don't want the wholesale because of even the minimum pain or fever. So then you do make sure that they come to you for their boosters and everything well, because it is said that if you give the boosters also of acellular pertussis properly and at the right time, then there is no breakthrough infections. That is what is actually being followed in Japan. Now,
How
there's a,
many
yeah,
how many year of protection does this wholesale and acellular, which are being provided by government or from us, provides, ma'am?
pardon, how many?
How many? I mean, the protection is not for lifelong. For DPT also,
No,
we
no,
are
no. After that's when
boosters.
you need to take the boosters at, you need to boost yourself at 5 years, at 10 years, and then every 10 years,
Okay,
because the immunity wanes off and you need the boosting effect.
okay. Thank
There
you,
are
ma'am.
two questions here. How about children from abroad? They have not had BCG before if the child is 7 years old. No, BCG, see, it's very clear that only up to 5 years of age. So if the child is 7 years old, there is no recommendation to give BCG as of now in India. Then there's another one. Many mother asking about HPV vaccine. What will be their dose? Will it be effective? If it's for the mother, yes, it will be effective, but not as effective when you give the dose at, say, 9 years of age. So usually the principle of giving an HPV vaccine at 9 years in girls, starting at 9 years in girls, and then also in an earlier age in adolescent and boys, is that they have to be protected before the first sexual exposure. So if you're giving it to a lady, a mother who is say 45 years or 30 years, she's already exposed, she may already be having HPV embedded in her cervicals um, epithelial cells. So in those cases, you can say, yes, it will be effective around say maybe 80-85%, but not as effective as it is in the uh, early, when you give the vaccine early. So there is one very nice concept about this HPV vaccine is that it actually, even if the patient has, some of the patients have genital warts, or they may have an indwelling CIN or something which is brewing up in the cervix. But if it is related to HPV, then if you give the vaccine, the antibodies actually combine with the virus and then neutralize it. So there is a little bit, not little bit, actually, there is a lot of advantage. And in countries like Canada, they say they don't look at the age, and they don't look at the age for both the sexes. So if somebody, say the wife suffers from cervical cancer, they will do a vaccination of the husband also at any age, and vice versa. So because of that effect, which has the antibody goes and combines with the human papilloma virus and neutralizes it. Now, if someone gets TT at 4 years by mistake, if someone gets TT at 4 years by mistake, then we have to give them tetraxim at 5-year visit, because TT is covering only tetanus. And here we cannot use Boostrix because Boostrix is Tdap. So at 5 years, you will use tetraxim, which is DTAP plus IPV. I hope that is clear. But the main concept of catch-up vaccination is that you need to give as soon as you get hold of the patient. You have to initiate the catch-up vaccination. And that is what is also the concept of Government of India by introducing the mission Indradhanush. They say that you want to catch up with all the missed vaccinations. MR given 2 doses in government, now coming for MMR. Yes, you give MMR, and we know that for MMR, you're also covering, the main idea of giving MMR is to cover mumps. So you need to give at least 2 doses, as in the schedule we have discussed. There is no problem of giving extra dose of measles or rubella. Minimum gap between TT and tetraxim. There is no minimum gap as such, because we already discussed these are killed vaccines. If you want to boost it up, say at 4 years, and they've come at you at 5 years, it's a good gap to give you, and you're within the schedule. But if you say patient has got a TT at 5 years and also due for the booster at 5 years, then there is no need to put a minimum gap, because we already discussed that any live vaccines can be given. Its only thing is that the tetanus part will be extra. How to give this MMR? Can you please elaborate? I have already shown you that this MMR, see, the patient has come to you now, had got MR 2 doses. So maybe patient has come to you at 2 years of age, and we had a mumps epidemic, and parents now want to give the mumps. They know that, they've come to know. So you start MMR now, give a second dose after 4 to 8 weeks. So we talked about a gap of at least 8 weeks between the 2 doses. If someone has taken Penta, PCV, Rota by mistake at 2 months, just 15 days later to first dose. So this dose will be considered invalid because you have given it only at a gap of 15 days. So you have to give another Penta and PCV and Rota at 28 days interval and then the 14 weeks. You can put a gap. See, now if the patient has already taken at 2 months, maybe the next dose you can give at 2.5 months. And then you give the third dose at 3.5 months to 4 months of age. We know that we can give a gap of at least 2 months in between these primary booster vaccinations, primary vaccinations. So any dose of any vaccine taken before the scheduled time will become, it's an invalid vaccination. Hexavalent vaccine at 6, 10, 14, should we add? No, we should not add. In the private sector, the recommendation from the IAP is that we are going to give only IPV. OPV we give only at birth. So in hexavalent, we will give only the IPV, no need to give the OPV. The only OPV which will be given in this situation is the ones which are given in the campaign mode, the pulse polio. So that we will advise the patient to, whenever there is a pulse polio campaign going on, they will go to the government center and take the pulse polio vaccination from there, the oral polio. I think that's it, Nitin.
Sure, ma'am. We will conclude the session. In case there are other questions, we will take it on the group, ma'am.
Yes,
Thank you
yes.
for your
Thank you.
time, ma'am.
Yeah, thank you.
Thank you everyone for joining.